Good evening, students. As I told you beforehand, I'll be talking to you today about hydronephrosis. Hydronephrosis means the dilatation of the kidney, or you can say the aseptic dilatation of the pelvi-calyceal system of the kidney due to obstruction to the outflow of urine. Outflow of urine from an obstructed kidney because of some problem in the pelvis, pelvic ureteric junction, or the ureter. Hydronephrosis may be unilateral or bilateral depending on the obstruction, which side is affected, or the both sides are affected. The hydronephrosis or outflow obstruction of the kidney with hydrocalyceal changes can be suddenly or it could be insidious, gradual onset. It may be a complete obstruction or it may be a partial obstruction. And let's find out what are the causes. The hydronephrosis, that the pelvi-calyceal dilatation, can be because of the causes which may be intramural, intraluminal, and extramural. That is, if the ureter is obstructed due to any reason, whether it is an external compression or there is something inside the lumen or in the wall of the ureter, it will cause obstruction. So let us discuss one by one. What are the extraluminal causes of extramural cause of obstruction? The extramural cause of obstructions are, as you see, when the ureter is compressed from outside. What are the reasons for compression of the ureter from outside? Is because of, number one, a tumor which is compressing upon the ureter from outside. The tumor may be in surrounding structure on the left, depending on the left side or right side is involved. So if it is in the left side, carcinoma of the rectum may obstruct the ureter and cause proximal obstruction and obstruction to outflow of urine and hydronephrosis. It may be malignancy from the cervix, it may be malignancy from the colon, or it can be malignancy from the prostate also, because prostate lies at the base of the bladder. Anyway, we will discuss these causes later on. And sometimes, the extramural causes of obstruction of the ureter may be because the ureter may be compressed by the vena cava. It's called retocable obstruction. There are certain causes in which the pathology is there inside the wall. And what can happen? The site which we call as pelvic ureteric junction may be obstructed. There may be congenital narrowing, there may be atresia, or at times there is compression because of the vessels, maybe some aberrant artery or the vein. Then other causes which are there in the wall of the ureter is there may be uretrocelular dilatation of the fluid at the lower end. There may be congenital narrowing of the ureteric orifice in the bladder, and there may be a stricture in the wall of the ureter because of infection. There may be a tumour inside, some kind of a growth in the wall of the ureter, or it is possibly that there may be inflammatory stricture, or there can be some kind of growth, as I have already told you. Then there may be causes inside the lumen. The most common cause of ureteric obstruction or the obstruction in the pelvis, it may be a stone which is lodged either in the ureter or in the pelvis of the kidney. Sometimes there are conditions, a person who is a diabetic or a person who is using or abusing non-steroid inflammatory drugs, there is a papillary necrosis. This papilla, renal papilla, gets sloughed off, gets detached, and may cause obstruction to the outflow of urine. So at times these are the causes which I have told you that the pathology lies in one side of the ureter and the pelvis, but at times there may be bilateral hydronephrosis in case these points which I have told you occur on the both sides. But the causes of bilateral hydronephrosis, if you see, is number one, it can be congenital or acquired. Congenital causes of bilateral hydronephrosis are in child who has got posterior urethral valves. These posterior urethral valves do not permit adequate and complete evacuation of the bladder. Second point of congenital causes for bilateral hydronephrosis is atresia of the ureter. Then comes, the acquired causes of bilateral hydronephrosis. What comes to our mind is that the prostate. Remember, for the sake of orientation, let me tell you, this is my right side, not the left side. This is my right side because I am on selfie mode. So I was talking to bilateral causes of hydronephrosis. Number one is benign prostatic hyperplasia. That means enlargement of the prostate, which is a feature of elderly people. The prostate gland, which lies at the base of the bladder, starts enlarging. There is a musculoskeletal involvement of the tissues. The second cause which is coming out of the prostate is carcinoma of the prostate. Then, a person who has been operated in past, he has got bladder neck obstruction. There is a stricture. So there is obstruction to the outflow of the urine. So therefore, person may be having bilateral hydronephrosis. Amongst the acquired causes, then a person has got, phimosis, tight phimosis, the external urethral meatus, and there is a tight prepuce narrowed, and the child is unable to pass urine. Occasionally, it has been seen that this may cause, not generally, but occasionally it may cause, obstruction to the outflow of urine and hydronephrosis thereof. Then other causes are, sometimes there may be detrusor muscle hypertrophy of the urinary bladder, which blocks the ureteric orifice. There may be tumour in the urinary bladder, cancerous growth obstructing both the ureteric orifices can also cause hydronephrosis. Now what happens? There are so many other diverse causes of obstruction to the outflow of urine. Condition called congenital megaureter. The ureter is lengthened, dilated and tortuous. Anyway, this goes out of the scope of what I am talking to you. Now, once there is obstruction to the out of the urine is being constantly secreted, but then it gets accumulated. There may be a sudden onset, and it may cause irreversible kidney damage in case obstruction persists for more than 2 weeks. Then it's very difficult to retrieve the renal function. And if the kidney function on that side or particular side goes less than 20%, some people say by 11%, the split renal function, the function of the single kidney, if we combine both the kidneys, if it is less than 20% for more than 2 weeks, we may have to do nephrectomy. That is the removal of the kidney. Nephrectomy means removal of the kidney, the excision of the kidney. So therefore, once there is a bilateral obstruction, something has to be done. At times it is also seen that there is a bilateral obstruction to the outflow of urine. In such cases, you may not find hydronephrosis because person goes into renal failure, and the failure occurs before the kidney has the compensatory change of dilatation. In hydronephrosis, when there is outflow to the obstruction of urine, the kidney ultimately becomes a balloon or a bag of water, a thin wall, where there is very thin cortical structure. And because of this intense pressure, which if the pelvis is intrarenal within the kidney, so the maximum damage will be done to the renal parenchyma. And if it is extrarenal pelvis, the pelvis will be dilated. The damage to the kidney would be lesser. In such situation, what happens is the nephrons are destroyed, the renal tubules are destroyed, and ultimately what is left is a bag full of water and a few septa inside. And if both the kidneys are involved, then renal function will be compromised. What are the clinical features when a person presents to you with unilateral hydronephrotic changes, when the kidney on one side is affected? Of course, when kidney is dilated, once there is obstruction to the outflow urine, the kidney will be distended, it will be enlarged, there will be a lump. You will feel lump, palatable lump, you know the side of the kidney. And it may be mildly tender. There is a swelling, there is a dragging type of a pain, and there is a tenderness also sometimes. And in case it becomes infected, it becomes a urine, hydronephrotic kidney becomes pyonephrotic, a person will have severe pain, he'll have fever and marked tenderness. And sometimes what happens is, it is called intermittent hydronephrosis. I'll tell you the term intermittent hydronephrosis. What did you say? I said intermittent hydronephrosis. Intermittent hydronephrosis means that a person has a hydronephrotic kidney, there is a lump, he gets a severe pain, and after that he passes a large volume of urine and the kidney lump regresses in size. This is called Dietl's crisis, D-I-E-T-L apostrophe S, Dietl's crisis. All right. So besides that, a baby might have been detected to have hydronephrosis in intrauterine life. Now, this kind of a disease can be diagnosed. And most of the children who are born like that, the postnatal investigations can reveal this thing. Now, there is a condition among females in whom during pregnancy, because of the hormone progesterone, there is dilatation of the ureters, both ureters, and she may get hydronephrotic changes in the first 20 weeks of the pregnancy. And once this kind of a stasis occurs, the urine which is having stasis is liable to be infected. The pregnant woman may have pain, fever, but after delivery, these hydronephrotic changes which occur because of rising levels of progesterone, it clears off in the next 12 weeks. All right. So hydronephrosis, because of the action of progesterone on the ureteric muscles, the dilatation will clear off after delivery after 12 weeks. Now, if a person who has got a hydronephrotic changes will come with a lump, number one, will have a dragging pain, number two, so you should always suspect that person may have hydronephrosis. Person may be asymptomatic also. So we have to do the investigation. What kind of investigation? Let's first do the basic investigation like CBC, like kidney function, like blood urea, serum creatinine. And if a person is having bilateral involvement, so his renal function will compromise. So his blood urea and serum creatinine will be raised. All right. Those are the basic investigations. You should do the versatile investigation for any kind of urinary involvement, the urine routine examination. Urine routine examination you can find. If you find there are pus, that means urine is infected. You can give him antibiotics. And if you find hematuria, patient is having pain, possibly one of the causes of hydronephrosis is a stone which may be stuck up in the ureter itself. The stone may get stuck where? There are 5 anatomical narrowings in the ureter. One is the pelvic ureteric junction. One place where stone can be arrested, which is in the kidney, but gets arrested in pelvic ureteric junction. Then second site is where the gonadal vessels cross the ureter. Thirdly is a place when the ureter enters the bladder. Okay, and the stone also may be stuck at the narrowed part, the ureteric orifice. In these places, there is a possibility a stone might be there, and that may be one of the reasons of hematuria. Thereafter, the very important investigation, which is non-invasive these days, what is that investigation for hydronephrosis? Excellent investigation. That is ultrasound. The ultrasound will definitely detect hydronephrotic kidney. It will detect the dilatation of the pelvis, dilatation of the calyces. All right. And it will also detect corticomedullary differentiation. All right. It will also be able to, as I've shown you just now, that pelvis is dilated and the calyces will become club shaped because of accumulation and distension of the calyces by the stagnant urine, the ongoing formation of the urine, and increasing amount of urine in the pelvis and the calyces. I want to tell you that if kidney function is not fully compromised, then what you can do is you can do certain contrast studies. Those contrast studies, basically, one is intravenous urogram. Intravenous urogram involves injection of a radio-opaque material into the veins, like urographin, which is excreted by the kidney. If a normal kidney, it starts, making its appearance within 5 minutes. But if there is obstructed kidney, there is a delayed excretion because renal function is compromised. Nephrons are destroyed, and renal tubules are also destroyed. So therefore, you can see dilated pelvis and you can see the dilated calyces. This is called intravenous urography or excretion urography. The whole, intravenous urogram, I may tell you that besides we have got so many investigations which have come up to diagnose, which have helped us in diagnosing so many problems, which has changed the outlook of surgical practice totally. But this is the intravenous urogram, you can say it is a dynamic and static investigation at the same time. It will tell you about the structure of the kidney. It will also tell you about the functional aspect of the kidney. Another good investigation for hydronephrosis, undoubtedly, but you see that ultrasound may not be able to tell you about the stone in the ureter, because ultrasound is not very good investigation to find out a certain, because ureter lies behind the bubble loops and it's masked by fat and gas in the gut. So therefore CT is a very good investigation for that. Then another contrast study is, if you want to find out the level of obstruction, you do RGU. What do you do? Retrograde urography. That you put a catheter from the urethra into the bladder, and through the ureteric orifice you inject a contrast material and you can visualize the anatomy, the level of obstruction. There is yet another very good investigation for hydronephrosis, which will also tell you the split renal function, the percentage of renal function of a particular affected kidney, and this is called Dtpa scan. What is this called? This is called isotope renogram. What is it called? Isotope renogram. Isotope renogram. That is diethylene triamine pentaacetic acid scan. Now this DTPA is injected, but is tagged with a radioactive material like technetium-99m. Once it is tagged to DTPA, this is excreted in the kidney, and it emits gamma rays, and it can be detected by gamma camera. So therefore, if there is obstruction, this material is remnant inside. It remains inside for longer time, for longer duration, because of the obstruction, and you can find out the level of obstruction also and percentage of renal function. This is called DTPA scan, diethylene triamine pentacetic acid scan, which is tagged with a radioactive material which emits gamma rays. The another, for conventional reasons, because of so many investigations which have come up, there is another test which is called Whitaker investigation, WHITKER. WHITAKER. WHITAKER. In this, what you do is, through a percutaneous puncture, you inject some amount of fluid into the renal pelvis. Once you are injecting percutaneously the fluid inside and kidney is obstructed, say at the ureteric level, so you measure the pressure will keep on increasing. Alright, this is called Whitaker's investigation. Now, as far as the treatment is concerned, if you do the serial ultrasound, you find there is a partial obstruction. There is a partial obstruction to the outflow of urine resulting in hydronephrosis. You repeat the ultrasound, and if it is deteriorating, if a person's status of the kidney is deteriorating as far as structure and function is concerned, if the hydronephrosis is increasing, number one, person starts having pain, number two, if the renal parenchyma is damaged or it gets infected, then there is a need for surgery. If it is outrightly pyonephrotic kidney, it's pus only, nothing else, then the treatment remains, firstly you must eliminate the function, otherwise patient might go into septicemia. It may become a threat to life. This life has to be saved. A pyonephrotic kidney, and if the other side is also involved because of renal stones, it is a dilemma. So therefore, on one hand, you have to preserve the function of the kidney which is functioning. Suppose there are renal stones on both sides. Which side you will operate first? You will operate on the side which is having better function, number one, so that you can retrieve the kidney. Okay. Or a side of the kidney which is having pain. So, this judgment of tackling which kidney to be tackled first, this priority requires experience, number one, and good amount of analysis and cross consultations, mutual consultations. The treatment of pyonephrotic kidney we'll discuss sometime later, but however, with pyonephrosis, the pus has to be drained either by percutaneous route, and such a kidney which has been infected, which is going to a bag of pus, there is no point retaining this kidney. First, they remove the pus, evacuate it, eliminate infection, give antibiotics, supportive measures, and in a fairly good time remove the kidney. There is no point, because person should not suffer lifelong because of repeated aspiration, repeated infections. Even it may cause some other problems. Xanthulogrammatus nephritis, and this is something like lingering on problems. So remove this kidney. At times there is kidney, the pelvis is blocked because of the renal stone. The hydronephrosis becomes pyonephrosis. You remove the stone in the hope that kidney function will improve. No, it might not. So better is it should remove. But however, if the kidney function is somewhere more than 20%, a person should be given a chance of surgery. And one of such operations which was commonly used, which is mentioned at your level, I would like to say, in situation like where there is pelvic ureteric junction obstruction or narrowing, or uretropelvic junction obstruction or agenesis, you can excise the narrowed segment, and you do spatulation of the ureter. That means you cut the ureter on one side, on the posterior side, straight, and if it is the extrarenal pelvis, I am talking about hydronephrosis due to pelvic ureteric junction narrowing or obstruction, the redundant pelvis is removed. I'll show you the snaps of it, and the spatulated ureter is anastomosed to the refashioned pelvis. And one should have in mind that either there should be a some kind of nephrostomy, but these days for to ensure the continuity of urinary drainage, one must stent the ureter by DJ stent. It's called double J stent, or any kind of a stent should be put, which is an internal drainage of the urine from the pelvis of the kidney and into the urinary bladder. It's a very, very simple. At the time of surgery, you can do it. You can place this catheter, and this procedure of doing anastomosis between the pelvis and the ureter after the excision of the narrowed segment is called Anderson-Hines operation. Anderson-Hines operation. As far as hydronephrosis, because of other causes, say there may be a retroperitoneal fibrosis. This is another, extramural cause of ureteric obstruction. So ureterolysis can be done. It may be, maybe encircled by a growth that has to be tackled, or there may be a stone inside the ureter that has to be removed. URS might have to be done. The next modality, if you do not want that person should be subjected to surgery, his condition is not good, you can introduce, a balloon or urethra, which is called endoscopic pyrolysis. That means you introduce a balloon from below, go to the site of obstruction, inflate the balloon, and you break the stricture. That might restore the continuity in case the person is unable to withstand these procedures. With these words, I thank you very much, and finally I'll show you a snap of Anderson-Hines pyeloplasty, in which ureter is divided, spatulation done, and this strap of ureter is anastomosed to the pelvis.